Kind invitation and introduction. It is always an honor and privilege to have the opportunity to participate in educational programs, especially those outside the United States. I'd like to thank Dr. Joe Servin for his kind invitation. My remarks will be restricted to the evaluation and treatment of patients with drug-resistant focal epilepsy. By way of disclosure, these are my personal and professional activities. We know that epilepsy is a very common disorder, and certainly patients with 2 or more unprovoked seizures would be considered to have a seizure disorder and warrant evaluation and treatment. But now there's compelling evidence that even individuals with 1 seizure who have biomarkers indicating the presence of a neurologic disease or an increased risk of seizure activity should be considered to have a seizure disorder. In the United States, over 200,000 Americans develop epilepsy each year. There is very compelling and sobering data from the Institute of Medicine report, and much of this was introduced by Dr. Joseph Servin, to indicate that epilepsy is a very common disorder, almost certainly underreported and underfunded for education and research activities in the United States. 1 in 26 Americans will have a seizure disorder during their lifetime. 10% or more will experience 1 or more seizures. This is double the number of individuals with autism spectrum disorders, multiple sclerosis, and Parkinson's disease combined. The economic burden of epilepsy in the United States and in the world is tremendous. In our country, it's $12.5 billion US. Nearly 2/3 of this expense is indirect. The need for a caregiver, unemployment, undereducated, inability to live independently. Over 90% of the cost of epilepsy is borne by individuals who have intractable seizure disorders that are physically, socially, and medically disabling. A significant reduction in the economic burden is early and effective therapy. When I see an individual who has a seizure disorder, I say we have 3 goals in mind. This is true in the United States, it's true in Mexico, it's true around the world. Our goals are for the patients to be seizure-free, to have no adverse effects of therapy, and to have no lifestyle limitations. The most important factor in improving the quality of life of the individual is for them to be seizure-free of disabling seizures, because of the putative beneficial effects in terms of driving, education, employment, and living independently. And why do patients have to be seizure-free to have productive lives? Because of their own individual goals. This individual lives in Indianapolis, Indiana, where the Indianapolis Motor Speedway is located. He had a left temporal lobectomy but was unable to drive previously because of his seizure disorder. He's showing you in his car his driver's license, and they opened up the speedway to make him 1 lap around the 2.5-mile speedway, which he sat and looked at during most of his life, unable to operate a motor vehicle. This is an older gentleman who had a right temporal lobectomy. He's at Machu Picchu at 14,000 feet. This vacation trip with his wife would be impossible with a disabling seizure disorder. Seizure-free after a right temporal lobectomy. And competitive athletics is difficult enough. And for those of us who are high handicap golfers, we know how anxious it can be to participate in athletic activities. This woman had a left temporal lobectomy, had a prior history of disabling seizures, and was the UK amateur athletic champion in golf. This is her entire trophy, and the caddy is her father. After epilepsy surgery, an impossible encounter if she had her seizure disorder. Now, epilepsy is not always a pretty disease with smiling photographs and trophies and cars. We know that 25,000 to 50,000 Americans die each year of seizure-related deaths. The comorbidity of epilepsy is significant. Cognitive disorder, psychiatric illness, injury, physical trauma, status epilepticus, and perhaps the most common cause of death, which is sudden unexplained death in epilepsy, or SUDEP. The pictures tell the story. A recent tonic-clonic seizure, facial trauma and fractures, need for surgery. Another significant problem in the United States and around the world is individuals who are operating a motor vehicle or using dangerous machinery when they have a seizure. This patient has a focal seizure disorder of temporal lobe origin, but assured me he always has an aura warning so he knows when to pull over. Despite the concerns regarding driving in the state of Minnesota, he continued to operate a motor vehicle, had a high-speed accident into this person's house. He was not injured. SUDEP is very important, and for those of you here in your residency and medical school years, you need to become familiar with the term. There's an excellent guideline which was produced by the American Academy of Neurology and the American Epilepsy Society. This is a really underappreciated cause of death, especially in younger people. How common is SUDEP? It occurs in children. It occurs in adults, 1 in 1,000 patient years. It may be the most common cause of death in younger patients who have seizure disorders, but it can occur in older individuals as well. Now, in the management of patients who have drug-resistant focal epilepsy, we have several treatment options. Curative surgical therapy, and you saw some elegant photographs from Dr. Zimmerman. Palliative surgery, designed to make a bad situation better. And this often includes implantation of a vagus nerve stimulator, continued anti-epileptic drug trials, ketogenic or Atkins diet, and investigational studies. And this afternoon we'll talk about some new emerging therapies as well. So when epilepsy is treated, how often is it effectively managed with anti-epileptic drugs? And these are the classic photographs that many of you have seen. Percent seizure-free. About a third of patients continue to have seizures on anti-epileptic drug therapy. And as a general rule, I tell patients the most effective medication for epilepsy is most likely the first medication. Use it very carefully. As needed, as tolerated, you advance the drug dose. The second most effective drug is your second drug. If 2 or more drugs are ineffective, the likelihood the patient has a refractory seizure disorder is significantly high. There has been a definition of intractable epilepsy that we can use, provided by the International League Against Epilepsy, and basically it's 2 or more anti-epileptic drugs. The likelihood your patient will be seizure-free if they're refractory to 2 or more anti-epileptic drugs is probably under 10%, especially if these medications have been used appropriately. Medication should be administered as needed. I use levels as a guide, but not as a therapeutic index. What about newer anti-epileptic drugs? And since we've been here at the conference, there's probably another drug to be approved in the States or elsewhere. It turns out in terms of efficacy, it's probably similar to the older medications in patients with refractory seizure disorders. But it does have different pharmacokinetics, different adverse effects. It may have unique mechanisms of action. We know, at least in the United States, it's much more expensive, and anti-epileptic drug levels are either difficult to obtain or very hard to interpret. So, epilepsy surgery, who are candidates? Well, for purposes of today's discussion, they should have drug-resistant focal seizure disorders. There should be some disability component associated with their epilepsy. That is to say, they have spells typically with focal impaired awareness seizures or tonic-clonic seizures. There should be a low risk for operative morbidity, including the evaluation prior to resection, and there should be a potential for rehabilitation. So we see the photographs of the person by the automobile, she wants to drive. A person standing next to a store, he wants to work. The individual at Machu Picchu, he wants to go on vacation at 14,000 feet. What are the reasons for surgery should be more than just reducing seizure tendency. There are 2 randomized controlled trials for epilepsy surgery versus best medical therapy. This is the one that's most commonly discussed. It's a randomized trial of 40 patients with surgery and 40 patients with best medical therapy. It was coordinated in London, Ontario, Canada. Surgery was more effective, and quality of life favored surgery. Who are good surgical candidates? And I'm going to play the role not of Dr. Zimmerman, a talented neurosurgeon, but of a neurologist directing traffic. Who are the patients that I am concerned may be surgical candidates? Realizing my goal here is simple. No seizures, no side effects, no lifestyle limitations. We're not talking about reducing seizure tendency for purposes of this talk, or palliative therapy. Patients who have neuroimaging, substrate-directed pathology tend to have the greatest chance of being seizure-free. And these are the common pathologies that we may identify. Fortunately, we have terrific tools to identify these pathologies. Young women who presented with visual aura, focal impaired awareness seizures, has a ganglioglioma. Had a lesionectomy, seizure-free. Patient presented with focal impaired awareness seizures, right temporal seizure discharges, has a very nice cavernous hemangioma in the right temporal lobe, excellent surgical candidate, seizure-free after surgery. This is a common pathology that we're now starting to identify that many of you probably have not seen in the practice of neurology or in medicine, which is focal cortical dysplasia, and this is the so-called transmantle sign on a FLAIR image. Look carefully because this might be your clue or your biomarker of the area or zone of seizure onset. We're finding many patients have either normal MRIs, or if you go back and look with many eyes, there's a subtle change. This patient had a normal MRI at multiple institutions, including ours. If you look very carefully here at the bottom of the sulcus, there's a blurring. And this was focal cortical dysplasia. It's the so-called bottom of the sulcus dysplasia. It's an epileptogenic lesion. It's developmental. It can be very difficult to see, very challenging for the neurologist and neurosurgeon. The most common MRI finding in patients who have epilepsy surgery as adults involving the temporal lobe is mesial temporal sclerosis. And many centers have come up with the observation of this in the 1980s, but Mayo was one of the pioneers in developing the technology and interpretation. You're looking at the face of the hippocampus right here. It's an oblique coronal section. Here's the normal hippocampus, here's the atrophic. You can see the size differential in the back row with a medical school education. It's very obvious. If you do in the same patient a FLAIR sequence, you see a signal change right here. This is evidence for neuronal loss. This is evidence for gliosis. You have the pathology. The neurosurgeon needs very little more information on this patient if they know they have epileptiform discharge in that temporal lobe. We looked very carefully at an evidence-based study with one of my fellows, Amy Jones, at is imaging help you with epilepsy surgery? And although we all have our strong beliefs, the answer is especially MRI. If you have an MRI abnormality like hippocampal atrophy that's concordant with the area of seizure onset in evidence-based medicine studies, you have a superb chance of being seizure-free. In the hands of someone like Dr. Zimmerman, 80 to 90%. Your chance of being seizure-free on that 14th combination of medicine that he showed us is close to 0%. We couldn't find a lot of evidence for PET and for SysCom because of the type of studies that were being done. But PET was particularly helpful if the MRI was normal for temporal lobe epilepsy. We looked a few years ago with a fellow from neurosurgery at almost 400 cases at Mayo Clinic who had an anterior temporal lobectomy with 10-year follow-up. And this is about the numbers. About 3 out of 4 are seizure-free. Now, many of the 20% who are not seizure-free had auras only or were even driving because they had focal aware seizures. But this is the numbers in terms of seizure freedom. I doubt if this has changed very much in the last 10 years. Typical patient has epilepsy surgery, a young woman I took care of. She's got left hippocampal atrophy. Neurosurgeon did a left anterior temporal lobectomy, and she's seizure-free. So I'll kind of show you a patient I followed. This is a woman from Iceland who we took care of, who had scalp monitoring, had bitemporal depths because we couldn't localize seizure onset, had a left anterior temporal lobectomy. She's about to go home to Iceland a few days after surgery. This was 3 years after surgery. She'd been seizure-free, and you can see the little bit of a dimple here on this side. And then she's always likes to send me these photographs. 10 years after surgery, seizure-free, off medication. These are our goals that we have for these patients. We're not looking to make the situation a little bit better. We're looking to make a profound change in their quality of life. I think this is the best evidence-based medicine review for epilepsy surgery. A lot of other things are observational studies, including my publications. But Barbara Yopes, who's at Dartmouth, and myself, was asked by Roger Rosenberg, the editor of JAMA, the Journal of the American Medical Association. It's a very significant journal in the United States, to look at epilepsy surgery. And the evidence is overwhelming that epilepsy surgery is effective in appropriate patients and is being significantly underutilized. When you looked at it compared to randomized clinical trials with medications, epilepsy surgery was more effective. But there are questions. We are very good at telling you how many are seizure-free. We're not good a lot at the quality of life issues. And despite the fact that there's very compelling evidence that we have a very effective treatment option, it's being significantly underutilized, certainly in the United States. If you do surgery early, the results are better. They're better not only in terms of seizure outcome, which looks very good here, but improvement of quality of life. And the longer these patients have intractable epilepsy, the more psychosocial baggage they pick up. Unemployment, not finishing education, need for a caregiver. Earlier, better than later. The average duration of epilepsy for the patients we had in that series of 400 patients was almost 20 years. That's probably 18 years too late for some of those patients. And you think of 20 years from now, those of you here in the audience, especially medical students, that's a significant time period of your life that you have to have intractable seizures. What about if the MRI is normal? I think we take a big step in terms of efficacy. I share Dr. Zimmerman's enthusiasm for SEEG and these other devices, but it seems like these patients, their likelihood of being seizure-free, driving the automobile legally and safely is reduced. This is a tough group. We know that the ictal EEG, as Dr. Zimmerman showed you, can be hopeless. They may have a pathology, and they usually need intracranial monitoring. And the reason they may be surgical candidates is because they're in desperate straits. And they have a significant impact on their quality of life, including sudden death. We did look at our institution at temporal lobe epilepsy with a normal MRI, 87 consecutive patients. The numbers are not as good. 55% seizure-free. Not as good. What about if the PET shows an abnormality? And this is a patient who had a normal MRI but has very significant PET hypometabolism. And that's when I'd like to use PET. Normal MRI, temporal lobe epilepsy, do a PET. About 80 to 90% should have PET hypometabolism if they have medial temporal lobe epilepsy. And there was a nice study done by another group, not ours, which justified the reason to do PET, because if the PET is abnormal, even with a MRI negative focal epilepsy, and they have a temporal lobectomy, their likelihood of being seizure-free is very similar to the group with MRI identified mesial temporal sclerosis. So this might be the useful indication for PET. Katie Noe was one of our fellows at Mayo Clinic in Rochester. Now she's at the Mayo Clinic, Arizona, an outstanding epileptologist. And she looked at a very important study that was really kind of initiated by the neurosurgeons. How many patients do we need to see at the front door with intractable epilepsy to know how many will walk out of the back door seizure-free driving home? That sort of analogy. And we looked at our toughest group, MRI negative, extratemporal. Dr. Zimmerman showed you some of those patients that he was putting devices in or SEEG. We tried to get 100, but 15 dropped out, so we had 85 consecutive patients. They all had a normal MRI, and they all had an evaluation which said they had extratemporal epilepsy. we found that many of these patients were not candidates for intracranial monitoring because even with the completion of the diagnostic evaluation, we didn't know where to put the electrodes. This was prior to the SEEG era, so I think Dr. Zimmerman would find places to put these electrodes in some of these patients. Some of them basically heard the risk and they walked out. So about 31 out of 85 had the intracranial monitoring, 24 had localized seizures. So 24 out of 85, so about 28% went on to have surgery. Most of these were frontal. Some of them did have focal cortical dysplasia, and we were fortunate none of them had operative complications. How many seizure-free? About 10%. So the whole group that comes in that room, about 10% leave seizure-free. In terms of those who had resective surgery, about 1/3. So a very challenging group to care for. But it's best we publish our data so we understand what the nature of the disease is, antecedent to the SEEG era. Hopefully we'll be higher. I think imaging is really very important. The three most component parts to decide if a patient is a candidate for epilepsy surgery is one is a very careful neurologic history about their seizure activity, seizure frequency, the use of anti-epileptic drug therapy, documentation of medication compliance and adherence, the effect on quality of life, the goals for the patient and their family, then a very good EEG evaluation, which can be routine, inpatient video EEG monitoring to record their typical events, and then neuroimaging. Those are the three important components. And the neurosurgeons agree with me that if you have a MRI-identified pathology that's concordant with the area of seizure onset, you have a very good chance of that patient being seizure-free, enthusiastically discussing epilepsy surgery. Now here's the advances, and they're coming very soon. And so you should be familiar with the terminology even if you don't have the technology at your institution. Double inversion recovery, functional imaging using different SysCom, and advances in signal strength. Here's a patient who has an intractable seizure disorder with a normal MRI. Now you say, well, it's not normal, but that's because you're looking at the arrow, okay? I'll take the arrow away, and I'll show you multiple images here. I'll get 100 people to raise their hand, and other than a few people in the room, most of you will say the MRI looks normal. This has the same signal intensity as the surrounding gray matter right here. And that is at bottom of the sulcus dysplasia, which is focal cortical dysplasia. This is what it looks like on a double inversion recovery. It stands out. It lights up the focal cortical dysplasia very nicely. And now you have a potential target or lesion for the neurosurgical team. We are now using clinical 7 Tesla MRI studies at Mayo Clinic Rochester, one of the first clinical centers in the United States. The scans are spectacular. What I don't know is will it make a difference in terms of selecting surgical candidates, triaging the evaluation, altering the surgical strategy, or improving the operative outcome. Don't know that yet. I do know it gives you very elegant photographs. The pictures of the hippocampus are the same as low power resolution in the pathology lab. So you just go back and study your anatomy, those of you in medical school, and you look at the hippocampus under the microscope at low power. That's what the 7 Tesla is. You can see all the subfields of the hippocampus. Look at the 7 Tesla images. These are non-invasive studies. This is my poor glasses that I had before I needed to get a new prescription. A little blurry. These are my new glasses, which have higher resolution. And that's kind of what the difference is between 3.7 and 7 Tesla. Not clear that new pathology shows up. You can see the vessels on 7 Tesla. This is an unenhanced study. This is the 3 Tesla. SysCom is also an important development, and we now have been using something called statistical parametric mapping, which looks at blood flow related to seizure onset. This can nicely show the areas of seizure onset. So here's our bottom line. Here's our scorecard, as we would say at our institution. How do we do with epilepsy surgery? Published data, clinical trials. And you can see that your chance of being seizure-free are the highest if you have an abnormal MRI, the lowest if the MRI is normal. One more caveat before I stop. Why should we do epilepsy surgery? No seizures, no side effects, no lifestyle limitations. That's our goals. We never talk about death. We think of epilepsy as being a benign, treatable disorder, kind of like migraine headaches. And I think migraine is a serious medical problem, and I think the doctors who care for migraine are excellent physicians, but we don't talk about death. We probably should be spending more time talking about death in patients with intractable seizures. There now is compelling evidence that if you do epilepsy surgery and they become seizure-free, you significantly reduce the risk of death. Significantly reduce the risk of sudden unexplained death in epilepsy. Despite all of this information, in the United States, over a period of about 20 years, there's been very little change in epilepsy surgery numbers. Patients are not having more surgery despite the diagnostic evaluations, the surgical strategies, and the surgical outcomes. So I'll bring it to the end, and I think that it's very important to keep in mind, whenever you're evaluating patients with epilepsy, that the care and management of patients with seizures goes beyond running the patient seizure-free. We must try to improve the quality of life of these individuals so that they can become participating and productive members of our society. Thank you for your invitation and your kind attention.